Now we're going to talk about the first true system of the body. We're going to talk about the integumentary system, better known as the skin. Now, the skin of the integument represents the largest organ of the body. It covers an area of 1.5 to 2.0 meters and accounts for 15% of body weight. There's three major regions to the integument. The epidermis is the outermost region, the dermis is the middle region, and the hypodermis is the deepest region of the skin. This is a little block that shows you a picture of a piece of skin, a little block, and it shows you the hairs, the hair follicle. The epidermis is this piece that they've lifted off here, the exposed hair shaft, and then showing you the dermis. The dermis has two layers, the papillary layer, the reticular layer, and then the deepest layer is the hypodermis. So just showing you the three layers and some associated structures. Now, the skin has a lot of receptors in it, so it does have the ability to feel through the skin. You have open-ended or dead-ended touch receptors here, pain receptors. You also have deeper sensory receptors called lamellar corpuscles or Pacinian corpuscles for deep pressure. And up in the upper layer of the skin, and I'm not seeing any here, but in the upper region here, you may have something called Meissner's corpuscles that are for lighter touch. This is an eccrine sweat gland. You can see the duct going out to the surface of the skin. There's the sweat pore. And then deeper into the skin, you'll see that you do have some larger blood vessels going into the hypodermis and also more adipose tissue or insulation in that lower level of the skin. So just going over some of the major structures, again, three parts: epidermis, dermis, hypodermis. Functions of the skin. Number one, the skin's very protective. We said earlier that the unbroken skin is a wonderful barrier to protect you from trauma and infection from the outside of the body. The barrier also prevents water loss and protects you from UV radiation damage. Vitamin D synthesis starts with a chemical that's found in the skin that's called cholecalciferol. It is the precursor to true vitamin D. Sensation. There are cutaneous receptors in the skin that sense touch and pain. Thermoregulation. The skin controls heat loss, or if you are overheated, it can cause heat loss through sweating and opening up the pores, and when you're cold, closing off those pores and retaining heat. Social functions. The skin is an important means of nonverbal communication. How you feel about your hair, your skin, what you look like is a good reflection on how you feel about yourself. Many times, if you have a birthmark, a scar, a pimple, or something in a place where everybody can see it, it makes you a little self-conscious. So those are all the general functions of the skin. We're going to start with the epidermis, and we're going to talk about the cells that are found in the epidermis. So the epidermis does have some stem cells, and these are cells that undergo mitosis and can become mature skin cells. And then you have your keratinocytes. That's what we call the cells that make up the epidermis. And then in the lower part of the epidermis, we have cells that are called melanocytes that produce the pigment. And so they give skin a little bit of color, and depending upon what your race is or how much you get out in the sun or whatever, these melanocytes can react in kind, and you will see different colors and variations in varying people. Some people don't have much color to them, and then you have people that have the condition known as albinism, where they don't produce any pigment at all. Merkel cells are down in the bottom part of the epidermis, and these are connected to sensory nerve receptors found in the dermis that give the ability to feel touch through the epidermis. Now, dendritic cells, also called Langerhans cells, These are phagocytic cells that are part of the immune system, and they will protect you if there is a breach or a break in the skin. They can actively destroy and engulf bacteria or any type of foreign agents that try to get in through a break in the skin. So those are all of your cells of the epidermis. Now here's the layers of the epidermis, okay? And the layers are called strata. Stratum is singular, stratus plural. So starting from the bottom, and we'll show where these cells that we just talked about, where they are and where they fit into the scheme of things. The stratum basal is the lowest layer of the epidermis. So it's the deepest epidermal layer. It's one row of actively mitotic stem cells. So this is where your stem cells are. And actually, this is a region where you will see your melanocytes. So your pigment-producing cells are down here, and your rapidly dividing stem cells, and your dendritic cells, tactile cells, are down here too. So here's your tactile cell attached to a nerve ending in the dermis. Here's your stem cells. There's your melanocyte. Okay, so lots going on in that first layer. Move out from there, and you get into this layer called the stratum spinosum. Now here you have several layers of keratinocytes, because that's what we call these tan-looking cells. Most of them in here, they're keratinocytes. And they're joined by desmosomes. Remember, the desmosomes are your cell connections that have a little bit of give. And so several layers. And this is where you'll find most of your dendritic cells or your Langerhans cells. So in this layer, you will find those cells and, again, cells of keratinocytes that are migrating away from the bottom. Now, incidentally, I want to ask you a question. How long do you think it takes from down here, where your stem cell develops and grows into a keratinocyte, slowly migrating away, how long do you think it takes to get from here all the way up to here? And at the top is where the cells are sloughed off. Actually, it takes about 30 to 40 days. So every 30 to 40 days on average, you produce a new epidermis, because you're constantly making new cells and they're constantly being sloughed off. So that's why if you commit a crime and you're not careful, you can leave pieces of yourself all over the place, because you're leaving skin cells, hairs, and all that behind. Okay, back to the story. So you have several layers here of keratinocytes, and then they move away, and then they get into this stratum granulosum. And at this point, they're kind of deteriorating. The cells are filling up with keratin, and they're dying off. Now, I want to go back to something else we talked about earlier. We said that epithelial tissue was avascular, but it's innervated. Okay, so this is all epithelium, right? All this is epithelium. Avascular, meaning there's no blood supply, but innervated, and we know it's innervated because we see this tactile cell here that's attached to a nerve ending, and that's in the lower layer, and this in the basal layer, so yeah, it's innervated. So where does the blood supply come from that feeds all these cells in here? Because these are living cells, right? And epithelium is avascular. Well, actually, they don't show you, but in the dermis, there are coils of blood capillaries that go up into the dermis. And by diffusion, oxygens and nutrients can diffuse away through the first few layers and make sure that these layers down in here, they get their blood supply. But once you get a few layers away, it's too far for the nutrients and oxygen to get there by diffusion. So what happens is, as the cells migrate away, not only are they filled up with keratin and glycolipid granules, but they also move too far away from the source of their supplies, and they die off. So the nutrients and oxygen are derived from the dermis, capillaries in the dermis. Just wanted you to know that. Okay, so the stratum granulosum is the last place where you'll find actually any living cells at all. And then you get into the stratum corneum, which is the most superficial layer, and that's 20 to 30 layers of dead cells, essentially flat membranous sacs filled with keratin, glycolipids in the extracellular space. So this is your thickest layer, makes up about 3/4 of the thickness of the skin, and cells are all dead at this point. Now, in very thick skin, like the palms of your hands and soles of your feet, there's an extra layer. And that extra layer is called the stratum lucidum. And on your notes on page 2, you will see that there. And so this is an extra layer that you would find in very thick skin. There's a question sometimes I like to ask on a test saying, if you had a splinter go into your skin on the sole of your foot, and it landed in the 3rd layer, say, just for illustration, which layer would it be in? Remember, the sole of your foot has the stratum lucidum here. So actually, 1, 2, 3, it would be in the granulosum. However, if that little splinter went into the ventral forearm, say the inner surface of your forearm, there's no stratum lucidum there, so 1, 2, 3 would mean that that splinter would be in the spinosum. So be prepared. You never know when you're going to have a question, something like that. So thick skin has that extra layer. Refer to the notes. It's mentioned on there. So the life cycle of a keratinocyte. From the stratum basal to the surface, it takes about 30 to 40 days. And when the cells are exfoliated away, that's dander. And they're tiny specks. And some people are allergic to different types of dander, like cat dander, dog dander, animal dander is problematic, and they're allergic to it. And you don't really see this stuff. It's very, very tiny. But in something like dandruff is where you have clumps of dander that are stuck together by oil from the hair follicle, sebum, and this is more visible and a problem in some people. Now we're going to go from the epidermis down to the dermis. Now the dermis has 2 layers. And the upper layer is the papillary layer, which makes up 20% of the dermis. And so this upper layer here is areolar connective tissue. Okay, and that's the universal packing material we talked about in chapter 4. The reticular layer makes up 80%, and that's dense, irregular connective tissue. All right, so really important, dense, irregular connective tissue makes up the bulk of the dermis, the papillary layer, areolar connective tissue. Now, here's the interesting thing. If you have a burn or irritate the skin where you get a blister is a separation of the epidermis off of the dermis. And this part, this papillary layer, because it's made of areolar connective tissue, that tissue can take on fluid very easily. So there are cells in here called mast cells that produce histamine. And the histamine causes inflammation, similar to what you have if you have a sinus infection and then you take antihistamines to reduce the inflammation. Well, the histamines cause this tissue to take on fluid. It swells up, and it bubbles up this epidermis away from the dermis, and it causes a blister. So that's why it's important to know that the papillary layer is areolar connective tissue, because it can take on fluid. And then this dense regular connective tissue, I'm sorry, this should be dense irregular here. Dense irregular, okay? So that's, make sure you change that, and I think it's on the notes. But once in a while, I'll correct myself. Dense irregular connective tissue, that's your reticular layer. Now, the hypodermis is the lowest part of the skin, and it's the subcutaneous layer because it's beneath the epidermis and dermis, which is called the cutaneous layer, and or superficial fascia deep to the skin. It's composed of adipose and areolar connective tissue. It does have quite an extensive blood supply too. Now, the skin does have variations in color sometimes, but there are some pigments that do contribute to skin color naturally. Melanin from melanocytes, and the melanocytes produce the only pigment that's made actually in the skin. And there's 2 types of melanin. There's eumelanin, which makes a brownish to black pigment, and then pheomelanin, which makes a reddish to yellow pigment. And that's why you see some people having variations in hair color, eye color, but the brownish to black, blonde hair, reddish colored hair is due to pheomelanin. Hemoglobin comes from the blood. Hemoglobin that carries oxygen changes the oxidation state of the iron, makes it very bright red, and you can see this more evident in people that have a very pale skin color. When they blush, you can see them, their skin get real pink and red when they're embarrassed. So that's another color. And then there's something that comes from food, keratin. Keratin is found in very high amounts in carrots. And sometimes if you have babies that eat too many carrots, and they become hooked on carrots and that's all they want, their skin will turn kind of orange. And it takes a long time to go away in the palms of the hands and soles of the feet because it's thicker skin there, and it takes a longer time to eventually get out of the skin. So those are 3 pigments that can affect skin color. And then there are some skin colors that are important in diagnostic evaluation of a patient. If a patient's skin appears like has a bluish cast to it, this is called cyanosis, and it could mean low oxygenation of the hemoglobin. Erythema is redness, and fever, hypertension, inflammation, allergy can result in a reddening of the skin. Pallor, whitening, blanching can result from anemia, low blood pressure, fear. Sometimes people lose all color because of fear. Anger to me should go up in the red category, but that's the way I react. Maybe some people get white with anger, but I get red. Albinism, we mentioned, is a genetic lack of melanin, so there is no pigmentation, and actually there's no pigmentation in the eyes or hair either. And because there's no pigmentation in the eyes, seeing the blood vessels in the choroid layer of the eyes will make the eyes appear more of a pink to a reddish color. Jaundice, yellow cast due to liver disorder. Bronzing of the skin is a problem with it's a endocrine disorder, a lack of steroid hormones that you find in Addison's disease, and we'll talk about that in the endocrine chapter. It's an adrenal cortex problem. And a hematoma is a bruise. Now there are skin markings to really maybe think about. Skin ridges are fingerprints. Everybody has this series of swirls and lines that you see that are unique to the individual. Flexure lines are areas where the skin folds. A lot of times they're found in joints and folds that you see in the palms of your hands. And it's where the epidermis is very tightly attached to the underlying dermis. Freckles and moles are local accumulations of melanin. And a birthmark is a hemangioma. And those are benign tumors of the dermal capillaries. Nothing to really worry about. And sometimes they will fade out as you age. Appendages of the skin. These are also derivatives of the epidermis, but they have different variations of keratin, which makes them a little bit more durable and dense than what you would find in the skin. So you have hairs and hair follicles, nails, sweat glands, and sebaceous glands. Hair is made up of dead keratinized cells, and what you have deposited in these cells is a very hard keratin, but it's more durable than soft keratin of the skin. Functions of hair include maintaining warmth, warning of insects on the skin, and guards the scalp against physical trauma, heat loss, and sunlight. You do not find hair normally on the palms of your hands, soles of your feet, lips, nipples, portions of the external genitalia. So that's a little bit about hair. Now, there's 3 parts to the hair shaft. The medulla is on the inside, cortex in the middle, and cuticle on the outside. And sometimes if you don't cut your hair and you allow your hair to grow very long and you brush it a lot, the wearing away of the cuticle will allow the cortex and medulla to frizz out and result in split ends. The erector pili muscle is attached to the hair, and when it's contracted, when you're cold, it results in these bumps in the skin called goosebumps. So that's the contraction of the erector pili muscle. You can also feel through your hair. You can touch your hair on your head without touching your scalp, and you can feel it. And that's the result of the root hair plexus, which is a little coil of nerve endings that surround the hair root that gives feeling to the hair. This is a cross-section through a hair root, and here's the 3 parts of the hair shaft, the cuticle, the cortex, and the medulla, and you can see those in the middle. And this is showing you the follicle. There's your erector pili muscle. There's a sebaceous oil-secreting gland that's associated with the hair follicle, helps keep the hair soft. And then your root hair plexus would be down here, although it's not shown, but a coil of nerve endings surrounding the hair bulb. This is the nail, and the lunule is the white part. The nail matrix is here where a new nail comes from. This is the free edge. This is the proximal fold. This is the distal fold. The proximal fold is here, and that's where the cuticle arises from. So not really much there. Sweat glands. We talked about these a little bit in chapter 4. I don't think it hurts to review a little bit. But your sweat glands are also called eccrine, merocrine, and sudoriferous. I mean, if there's not more names you can give to any one thing, I don't know too many things that have so many names. But again, all surface areas of the skin except nipples, parts of external genitalia, about 3 million per person. And your two main types are your sweat glands and your apocrine sweat glands that have more fat, axillary region, armpits, and anogenital region associated with body odor because of the fat that's metabolized. Modified apocrine glands, you have ceruminous glands. These line the external ear canal, and they secrete cerumen, which is earwax. And then there's modified sweat apocrine glands called mammary glands that secrete milk in the breast tissue. Now let's go to skin cancer. Most skin tumors are benign, not cancerous, and they do not metastasize, which means they do not spread. Some of the risk factors for skin cancer: overexposure to UV radiation, frequent irritation of the skin. Now, there are lotions out there that contain enzymes that can repair damaged skin, and there's 3 major types of skin cancer: basal cell carcinoma, squamous cell carcinoma, and melanoma. And when we were talking about the skin, and we were talking about the epithelium, remember, because most of your cancers come from epithelium anyway, when we said that in the epidermis you get past the spinosum layer, and beyond that point most of your cells are dead anyway, right? So any type of skin cancer you would get would be an epithelium associated with those lower layers. So this one right here involves that basal layer of rapidly dividing stem cells in the epidermis, the basal layer. This type of cancer here, squamous cell, comes from the stratum spinosum. Again, cells that are new, they're living, they're not too far away from the dermal blood supply, where your nutrients come from the dermis, okay, so living cells there too. Melanoma comes from the melanocytes. Anything beyond that, the epidermal cells are dead, so you wouldn't have cancer coming from any place else but those lower layers. So basal cell carcinoma is the least malignant, but also the most common. Stratum, basal cells proliferate and slowly invade the dermis and the hypodermis, but if you catch them early enough, you can be treated with these 99% success rate by surgical incision. And a lot of times people have these things frozen off to liquid nitrogen. Squamous cell carcinoma, the second most common type, involves keratinocytes of the stratum spinosum. Usually scaly, reddened papules on scalp, ears, lower lip, hands, does metastasize, but the prognosis is good if it's treated early enough by radiation therapy or removed surgically. The most deadly of all the cancer types is melanoma, and this is cancer of the melanocytes. It's highly metastatic and it resists chemotherapy, so it's very difficult to treat. And if you recognize it and diagnose it early enough, and you can get a wide area of skin excised along with the cancer and follow it up with immunotherapy, the survival rate is good, but you've got to catch it fairly early. So the key to survival is early detection. And there is this rule called the ABCD rule, and sun worshipers should use this as a way to evaluate maybe spots that you might see and whether you should have them checked or not. A stands for asymmetry. The two sides of the pigmented area do not match. B, border irregularity. If the spot exhibits indentations and it looks like it's maybe growing little roots or something, might need to have that looked at. Color contains several. Could be brown, black, tan, sometimes red or blue. Any variations in color, get that checked. Diameter, anything larger than a 6 millimeter circle, which is around the size of a pencil eraser, don't hesitate to have somebody look at that. There's also E. E stands for elevation. So if something is elevated above the surface of the skin, maybe something you want to have a skin doctor look at. So here's some different types of carcinoma, and you can see here's basal cell, what it looks like. Squamous cell carcinoma, a little more reddened looking, and melanoma. Get some very interesting colors with that. And again, the most dangerous of all your skin cancers and nothing you want to mess with. Now we move on to burns. And burns are classified by severity. A partial thickness is a first degree and second degree burn. So a first degree is epidermal damage only. Localized redness, edema, a little swelling and pain. But in order to get the blisters, you have to get into the upper part of the dermis where that areolar connective tissue is. So second degree is epidermal and upper dermal damage, and the difference between this one and this one is you have blisters. You have the redness, the edema, and the pain, but you have the appearance of blisters. Full thickness, third degree, entire thickness of the skin is involved. A lot of interesting colors here. Not painful because the nerve endings are destroyed initially. It's not painful. And not usually swollen because you burned off most of the skin. Skin grafting is usually necessary in third degree burns. This is how they evaluate severity of burns based on the rule of nines, how much of the body is affected. So the anterior and posterior head and neck is 9%. You can see everything's multiple of nines. Anterior and posterior upper limbs, 18%, anterior and posterior trunk, 36%, perineum, 1%, that's what's left over because 9's multiplied together, 99%, so that's the 1%, anterior and posterior lower limbs, 36%. So this is how they evaluate the percentage of the body that's injured. Now, here's first degree burns, the redness, second degree with the blisters, and then third degree, it looks like cooked meat to me. Very, very serious. So when you have a third degree burn, the first thing that you worry about is loss of fluids. Hypovolemia and dehydration can be the initial cause of death. But over time, if a person escapes the first 48 hours and is able to survive, the real major cause of death from burns is infection. Because remember, when you take away that barrier, the unbroken skin, and that's compromised, infection can go rampant and septic very easily. And people usually from third degree burns can die, days to weeks later from massive infections. So very serious. So burns are critical if 25% of the body is second degree burns, 10% of the body is third degree burns, and face, hands, or feet bearing third degree burns. Treatment includes debridement, removal of the burned skin. I heard that's hideous. It's extremely painful to have done. You have to really, really treat with lots of antibiotics, temporarily covering the area, and skin grafts wherever necessary. And that's the end of chapter 5.